epidemia del Hospital Krankenhaus en Austria y nos va a hablar de cuándo está indicada la urodinamia en las mujeres. Could I have my slides, please? Well, dear colleagues and friends, it's now my privilege to talk a little bit about the functional urology and focusing on the questions whether urodynamics are indicated in women with urinary tract symptoms. I think it is clinically relevant. The answers are clinically relevant, not only from the clinical point of view for daily practice, but also from the economic point of view, because you know that urodynamics are time-consuming and they are expensive. Before I start, I will just bring you greetings from Innsbruck, where I work and live. That's a town in the western part of Austria, surrounded by the Alps mountains, and we also host a medical university. And here, this is the hospital complex with about 1,300 beds. And I had the opportunity to establish there almost 3 decades ago a neurourology unit. But back to our topic, to the role of urodynamic study. I will do this by answering the questions whether urodynamics are indicated in overactive bladder, under which situations, in urinary incontinence, with pelvic organ prolapse, and what is the role of urodynamics in suspected bladder outlet obstruction in women. Let's start with the overactive bladder. I think you are well aware that there are 2 different types. We have the uncomplicated OAB with expected symptoms like urgency, frequency, with or without urgency incontinence. And on the right side, we have the complicated OAB with all these symptoms listed up here. I think the initial management of a woman with overactive bladder symptoms are after a general assessment, urinary symptoms assessment, including very important and essential avoiding diarrhea, urine analysis, and if there a urine UTI is present, then treat the patient first and reassess. You should also measure the post-void residual urine. You should assess the quality of life and the desire of treatment. And in regards to physical examination, abdominal, pelvic, perineal, and pelvic floor, you should not forget to do the cough test. And as you see, urodynamics are not included. What is the rationale against urodynamics in uncomplicated OAB? Well, it was shown by Hashem and Abrams and others that the correlation between urinary tract symptoms, clinical diagnosis, and urodynamic diagnosis are often poor. There's only weak association between the sensitivity for detrusor overactivity for the symptom urgency incontinence is very low, the specificity quite well. And that's a very important point. There is a variability of urodynamic observations. We know that also in women with overactive bladder symptoms, only 64% show detrusor overactivity, and only 83% of those where you see urodynamic connected detrusor overactivity have really the symptoms of overactive bladder. So I think the variability is a very important issue. It is one of the reasons why urodynamic observations are not closely associated with symptoms. Examples, the bladder sensation, the volumes during fetal cystometry may vary. There is less detrusor overactivity when you do a second run, when you do a second filling period. And the occurrence of urgency and urgency incontinence is not always the same day. And this is a very interesting paper published in Japan by Japanese colleagues, and he could show very elegantly that even in these patients, these women with overactive symptoms, urgency episodes occur less than once a day in 43%, and there were also days without it. And so if you investigate the lady just on such a day, you won't find any detrusor overactivity. So sometimes, well, there you have to use some provocative tests to detect detrusor overactivity. Here, for instance, you see that is a so-called hand dipping into cold water. Sorry, I have to go back. Okay, then. Yes. And you see, some patients, when they come in contact with cold water, then you can stimulate the overactive detrusor contraction. As you see, if an error tips his hand in cold water, he provokes a detrusor contraction. There was also another method developed, and this is ambulatory urodynamics. What does it mean? It means that the patient has the catheters in, and they are connected to a little computer which is worn on the belt. And so, under daily life circumstances, you register the pressure of the bladder and the rectum, and you also can detect urinary loss. So this is a comprehensive curve. Afterwards, it's hard work to analyze that, and then you will see in this picture, for instance, the intravenous pressure in blue and the detrusor pressure in yellow, and you will surely see that there is a detrusor contraction, which was not be found in under normal conditions. However, this method is discussed very controversially, and I think it's not very popular nowadays. Well, what you find at the end in regards to the detrusor overactivity, there are two different types. One is the so-called phasic detrusor activity. You find this in younger people. You know, they have a detrusor contraction going along with the urge to void, sometimes without, or with urinary incontinence, sometimes without. But in the elderly population, we have very often what we call terminal detrusor overactivity. That means you are filling the bladder. You fill the bladder and the patient has no pre-warning. You normally have a pre-warning when the bladder is getting full. You feel the urge to void, and it becomes stronger and stronger. But these patients, they don't feel anything, but suddenly a strong urge comes up together with the detrusor contraction. And this terminal detrusor overactivity then leads to urges incontinence. So, the role of urodynamic study in ORB. According also to the most recent guidelines on urinary incontinence from 2015, you can load them now from Europe. The rules are, or the recommendations are, before you think about urodynamics, do non-invasive urodynamics. We do not do any urodynamic in our institution without avoiding diarrhea of the patient. Or without having a free flow before the urodynamic extubation, and once we have evaluated post-void procedure before the urodynamic extubation. But the conclusions in the guidelines are invasive urodynamics not necessary prior to treatment in women with uncomplicated ORB with no symptoms or signs or other voiding dysfunction. However, invasive urodynamics prior to treatment are necessary in women with complicated ORB, with an unclear diagnosis after initial management, and with initial management phase. So let's come to the second point. How about a lady claiming urinary incontinence? Are urodynamics really always necessary? Well, I think we have to realize that there's a value of urodynamics for the evaluation of urinary incontinence. Firstly, with this method, you can really differentiate between stress and urge incontinence. You can prove the detrusor activity, as you have seen, and especially when you combine it with video dynamics, you can recognize maybe the underlying pathophysiology for urge incontinence, as I will show you in a few moments. Just to differentiate between stress and urge, you have here the schematic of it, the intravesical pressure, the intrarectal pressure, and here the flow just to showing whether there is involuntary loss of urine or yes or no. And in typical stress incontinence, when the patient is coughing, synchronously with the cough, you have loss of urine. But there can also be a situation where the patient says, well, if you ask, they say, well, when I'm coughing, I lose urine. But then it can be also this situation on the right side. The patient is coughing, you have the simultaneous increase of pressure in the bladder and the rectum. But this cough induces, in an overactive bladder situation, an involuntary diffusive contraction, and about 5 to 6 seconds later, then the patient has an involuntary loss of urine due to emergency incontinence. So this is a very elegant method how you can really differentiate. You can do it also with a cough test, but you have to be very careful. You have to look at the patient. If really the urine loss is synchronous with coughing, then it's stress incontinence. But sometimes the patient is coughing, and you see the involuntary loss of urine maybe 5, 6 seconds later. This is characteristic for urgency incontinence. Well, Ed McGuire, who was previously in Ann Arbor and then in Houston, he designed also the so-called the measurement of the cough leak point pressure in order to quantify the amount of sphincter weakness. And then also in Germany, two colleagues developed such a device where you just you measure only the intrarectal pressure, and you measure also for detecting loss of urine, the urofluid. And then you can ask the patient to start straining, and maybe firstly not too much, and then comes the point where you can see now the patient starts to leak, and this is the so-called leak point pressure. However, this was very discussed within the last years, and I remember that Professor Ed McGuire said once during such a discussion, I wish I would have never described this method because it is so controversial. But okay, you can also, with this simple device as I've shown, you can also detect, for instance, the typical sign of urgency incontinence, as you see here. Again, the cough is here, but the lesions of urine is later. Another, I think, video urodynamics can be of importance to detect the underlying pathophysiology for urinary urgency incontinence, as I will show you on the next chart. This is a lady with mixed incontinence, but predominantly urgency incontinence. And during the filling, you can see on the video that due to the incompetent bladder neck, the urine goes into the posterior urethra. And the more the bladder is filled, the more urine comes out here into the posterior urethra, and then eventually stimulates a diffusive contraction. So you have the impression that this is urgency incontinence, but the underlying pathophysiology for this phenomenon is the incompetent bladder neck. And if you give this patient, just because from the history, antimuscarinics, she will not be happy. She needs really an anatomical reconstruction of the bladder neck, and then also urgency incontinence will disappear. Let's have two cases. This is a 20-year-old woman with a chief complaint of stress urinary incontinence. The leaks with straining, the denies difficulty in emptying, no urgency symptoms or urgent urinary incontinence, no prior history of acute surgery, no comorbidity, urethral hypermobility, you see it, and there's no prolapse. The stress test is positive, and you have a low post-vital urine. Would you do before prior to operation? If you think you should operate her, would you do urodynamics? Well, let's see the next one. In this patient scenario, instead of an uncomplicated stress urinary symptoms with a almost normal post-vital urine and a positive stress test. I think these cases are not so frequent where we have pure stress incontinence without any voiding, without any symptoms of urge, but they are. And it is reasonable in this scenario to proceed to discuss the treatment options, including including surgery, without urodynamics. So recommendation, discussion of treatment options. Let's see another lady, more or less looks almost like the same. 42-year-old, links with exertion, denies difficulty in emptying, but has moderate urgency without urinary urge incontinence. There's a previous bladder lift, probably urge, no comorbidity, urethral hypermobility again, no prolapse, positive stress test, and post-baptismal urine. Would you consider urodynamics before you do any further procedure? Well, I think you have to realize in this patient the scenario is more complex. She has storage symptoms of urgency and stress urinary incontinence. In addition, there is a previous procedure was performed. This scenario seems to be more complicated, and preoperative urodynamics may be helpful. When doing urodynamics in this complex setting, urethral function should be measured. You can do the stress deep point pressure. So the recommendation is do pressure flow studies and assess the peak point pressure. Well, let's come to the third one, that's pelvic organ prolapse problem. Again, let's start with the case. That's a 77-year-old woman with a chief complaint of vaginal bulge. She failed pessaries several times. She denies stress urinary incontinence or urgency. She denies difficulty with the bladder emptying, no sexually active. She had a status was hysterectomy. She had a myocardial infarction 2 years ago. Physical examination, a total prolapse with a pelvic organ prolapse quantification of 4, which is quite high. And she has a post-baptismal urine of 40 mLs. Before you do the prolapse operation, would you recommend urodynamics in this lady? You know, one danger with if you correct the prolapse is that before she is continent, and once you have lifted up the bladder, and once you have removed the prolapse, then stress urinary incontinence may occur. So is urodynamics justified? Well, in this scenario, the patient has no associated LUTS or stress urinary incontinence. If the decision has been reached to perform POP surgery because of bothersome prolapse symptoms, a stress test with the prolapse reduced will reveal whether this patient is at significant risk for post-operative occult stress urinary incontinence. So multi-channel UDS is optional if all the necessary information has been obtained during this test, so it's not obligatory. Next one. So the recommendation is when you reduce the prolapse during clinical investigation, you ask for the stress test, and then you have done what you should do. And the next one is again a 77-year-old lady, again failed pessaries 3 times, but denies stress urinary incontinence, but has clear urgency. It's a moderate difficulty of bladder emptying. She's again not sexually active, has a status of a hysterectomy with a infarction 2 years ago. A total prolapse, the pelvic organ prolapse quantifications again 4, and the post-baptismal is 40 mLs. How is the situation in this lady? Would you do urodynamics? Yes or no? Well, I think in this patient there is associated storage symptoms, such as urgency, and they are emptying the urinary tract symptoms as well. And this complex constellation of symptoms may be better assessed with urodynamics, and the stress testing with prolapse reduction can be performed during the urodynamic setting. Thus, all the desired information pertaining to LUTS and whether or not occult urinary stress incontinence will be obtained with urodynamics. So you see, it is the history which is decisive whether you do urodynamics or not. But there is a tendency, especially also from the UK, that in pure stress incontinence, there is no need for doing urodynamics before surgery, and the same is with the organ prolapse. If you just the organ prolapse, you can find what you want to know also by clinical testing. And the last one now scenario is suspected bladder outlet obstruction in women. Is there something special with urodynamics? Yes, there is. Firstly, if you look in the literature, the incidence of that outlet obstruction in females varies between 1% and 30% in patients having women having urodynamic symptoms. Why these variations? Firstly, I would say that outlet obstruction in females is not well defined, and there are different definitions. And in men, we have these pressure-flow relations, and based on them, the normograms were established. But these pre-normograms were developed for men with proximal obstruction in the proximal flow controlling zone, where the flow is driven by the detrusor pressure. However, this cannot be assumed to be correct for women in general. Many women, flow is driven by the intravascular pressure, so that straining is very effective in men's flow rate, even at the low detrusor pressure. So you cannot use these normograms from ladies. And this is also reflected in the history, in the literature, when it comes to the definition. What is really an outflow obstruction in women? Massa and Adams said if two or more of these four parameters are present, then it is you have a suspicion of an outflow obstruction. A Qmax below 12, a maximum detrusor pressure above 50, urethral resistance higher than 0.2, and significant post-workers in the urine. Well, there are others. Nitti, for instance, in New York, he says there are no strict pressure flow criteria, and his diagnosis is based on the radiographic evidence of obstruction between the bladder neck and the distal urethra, and a sustained detrusor contraction. And another colleague in France, he says, well, if you have a flow rate in a woman lower than 15 ml per second, and if you have a detrusor pressure, maximum detrusor pressure lower than 20, then you are higher than 20, you see the previous author said 50, then he says this lady might have an obstruction. I think, therefore, we cannot rely on these numbers. I think the most important thing is the visual judgment of the tracing, which gives information about the underlying pathophysiology. If you have an obstruction, you assume that you have a high detrusor pressure, elevated detrusor pressure, low flow. The same low flow you can also have with detrusor weakness. And this differential diagnosis you can only make with urodynamics. And well, I saw one lady in one of the Latin American countries, and was amazed that this lady had a distal urethral obstruction, and you see that she had a detrusor pressure almost 200 centimeters of water and a very, very low flow. It's very significant that she has an infravascular obstruction. So, in summary, indications for urodynamics in women with lower tract symptoms, according also to the latest guidelines of the European Association of Urology, in OAB, there are indications for urodynamics with complicated OAB, with an unclear diagnosis after initial management, when initial management fails. In urinary incontinence, if you have a stress urinary incontinence with storage symptoms, and with if you have a recurrent stress urinary incontinence, you should do urodynamics. However, this is a change between the most recent guidance and the previous ones, that if you have a pure urinary stress incontinence in a lady, there is no need to do urodynamics before. And in POC, you only should do urodynamics when associated with storage symptoms, voiding symptoms, and in regards to bladder outflow obstruction, you have to be aware that the diagnostic workup for women is not yet standardized, and there are no useful